The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD Warriors. We are here gathered for the next installment episode of TMD Demystified, and I am Tony Urbanic. Today's episode and topic is burning tongue and TMD. Now, this particular topic was generated by a recent experience I had with a patient here that I actually saw in my practice. I found it absolutely stunning and stimulating and important to report on this. And this is actually the first place that I'm going to bring this topic up. Like some other topics, it's a little technical. I have found that the technical topics do not get as many views as some of the other topics, but I do encourage you not to be dissuaded by watching this episode because it may not sound interesting. And this is the reason it is interesting. If you are a general dentist, an oral and maxillofacial surgeon, or an orthodontist, I promise you, if you've been in practice for more than 5 years, you have seen several patients who have come into your office, either your own patient or come in de novo with their complaint of burning tongue or burning mouth. Basically, it could be the same. Patients have a burning tongue, they would more than likely describe it as a burning mouth, but burning tongue specifically. So here is a case study based on a patient that I saw approximately 2 weeks ago, and it is extremely relevant to TMD, and I'm going to take you through this as rapidly as I can. So I saw a patient who is a current patient of mine. She had been under treatment for TMD and had verified most of the usual symptoms: headache, earache, jaw pain, neck pain, had some of the other symptoms of vertigo and ringing in the ears. And she had been under treatment for several months and had good results. The last time I saw the patient prior to when I saw her 2 weeks ago was about 4 months. And her stated percent of overall symptoms, average number of symptoms that were resolved, was 75%. And then I lost her to follow-up and didn't realize it, but 4 months later, she comes into the office, and her chief complaint is that the symptoms are returning. And I review the chart, and then I start asking a few questions. I guess the first question was, what happened? I haven't seen you for 4 months. And she gave me the following history. She had a medical history prior to that she had had carotid endarterectomies on the left side. She had 2 separate surgical procedures for carotid endarterectomies for transient ischemic attacks over a period of several years. But recently, from the time that I saw her prior, 4 months ago, she had entered a local hospital and had placed a stent. Instead of just reaming out the obstruction in the carotid artery, the surgeon elected to do a stent in the carotid artery. And her history, as I ask her a few questions. She said it was really devastating that immediate 2 days after surgery, which was clinically successful, she began having significant, severe burning tongue. History of burning tongue. Symptoms of burning tongue on the left side. And she said that she had seen several doctors. She had not seen me, but she had seen multiple doctors, and no one could figure out why she had burning tongue. And it began 2 days, 48 hours after she had her surgery. She said eventually, within a couple months, the burning finally started to subside gradually. And it wasn't completely gone, but it had the major discomfort had diminished on the tongue by the time she came in to see me 4 months ago, or 2 weeks ago. And I listened to her, and I really thought there was something there. I didn't quite know exactly how to address it at the time, but her concern when she came to see me is her symptoms had returned. She was afraid to put her device back in her mouth when her tongue started to burn, and that was roughly 2.5 months prior to the time she came in to see me. So the timing sequence is that she had this carotid stent placed, 48 hours, began having burning tongue, and didn't put the intraoral device or Urbanic device in since that time. She was afraid to. And now her symptoms, her TMD symptoms, were returning, which was expected and predicted if she wasn't going to wear the device. So I looked at the device. It was set up correctly, and the solution was just put the device back in. I put her back into 24 hours, 24/7 for a short time, and then we'll go to nighttime, and I'm sure it resolved the problem. We'll get her back to 75% of her symptoms and above, because it's time dependent. But I was struck by the timing of her burning tongue, which she had never experienced before, and the fact that she had this surgery. And of course, as a surgeon myself, I was rather interested to see if there was a correlation between the surgery itself and her burning tongue, and possibly her TMD. And this is after I didn't do it in the room at that time. I just sent her along and said, I want to see you back in a month, put your device in. But that night I sat down and began ruminating on the circumstances, and I realized what had happened here. Now, can I prove this? Is it scientifically proven, statistically proven? No, this is a case study. This is a case study. But I think that I'll be able to make the point, and it certainly makes sense. And for those of you who are watching this, who have seen patients who come in with burning tongue, and of course, there is no solution, to the burning tongue. Topicals, the usual thing is topical anesthetics. Oh my God, I have probably seen 4 dozen patients, at least 4 dozen patients in my career, who have entered the practice, and the only complaint was burning tongue. And they, as the oral maxillofacial surgeon, where else are you going to send these patients? And they came from general dentists and PCPs, and they came all over the place. I mean, at least 4 dozen, 45, 48 to 50 patients in a career. Yeah, that's easy to see. All right, so burning tongue is not common, but it's common enough, and no one knows what to do. Miracle mouthwash, at least around here in the Southeast, is very common. Miracle mouthwash doesn't help. Topical anesthetics doesn't help. But this is what I'd like to show you, that I figured out really what's going on here. So, and any kind of general anesthetic, certainly doing a carotid stent, the patient was placed under general anesthesia, and the anesthesiologist opened the patient widely to place the endotracheal tube. I've done that thousands of times. I'm very familiar with the procedure, and any anesthesiologist struggles a lot with getting the mouth open wide enough, especially with a patient with TMD symptoms, so that they can get the endotracheal tube down placed correctly and easily. So I am certain, because this patient already had a history of TMD, that the anesthesiologist struggled a little bit getting the patient open fully because of scarring associated with TMD, and overextended the temporomandibular joint, which certainly would stir up inflammation within the temporomandibular joint. Typical, we see it all the time. We see it all the time. Patients going through general anesthesia, they come in after general anesthesia, and within a few days, they complain of symptoms associated with TMD. That is a common event, common event. Or patients going to the general dentist and having their teeth cleaned, or an operative procedure in dentistry, wisdom teeth, especially root canals, open for an hour or more, 2 hours, doing an upper second molar root canal. Patients will, if they have the disease to begin with, they will complain of TMD symptoms because it stirs up the inflammation in the joint. Well, that's exactly what happened here, but anatomically, how does that convert into burning tongue? And this is what I'd like to show you. Let me bring this up. This is a diagram that I think I've brought this up on other episodes, basically just to describe how close the temporomandibular joint is, the glenoid fossa of the temporomandibular joint is to the middle ear, relevant to Meniere's disease, tinnitus, subjective hearing loss, and vertigo. And so those of you who watched that episode, you're familiar with this slide, but I'm going to recap it a little bit just to show you that the petrotympanic fissure, which this is a slide right out of a 50, well, it's probably 60-year-old copy of Gray's Anatomy. Well described, well understood. The petrotympanic fissure is a fissure, an opening, potential opening from the posterior aspect of the glenoid fossa, which goes actually from here in a short distance into the middle ear. So that is the petrotympanic fissure, which I've described earlier. It gives the opportunity of inflammatory exudates and fluids, possibly cells, couldn't be sure. But the exudates certainly can come up through the fissure into the middle ear, making changes in the biochemistry of the middle ear, the fluid in the middle ear, thus causing subjective hearing loss, tinnitus, and vertigo. And we know that that happens because when you make the inflammation in the temporomandibular joint diminish, then those three symptoms associated with Meniere's disease will diminish. We've seen that, if not 1,000 times, at least hundreds and hundreds and hundreds of times in this practice. So the petrotympanic fissure gets into the middle ear. And here is a companion slide looking from the interior of the middle ear diagram, again, of the petrotympanic fissure. One of the other names for the petrotympanic fissure is the Glissarian fissure. I believe it was Dr. Glissarian who initially noted this fissure. You can see it is literally a highway in the bone, but this is what I wanted to bring to your attention. Again, for those of you who see the uncommon event, but not so uncommon that you don't get to see it every year or two in your practice, here's the chorda tympani coming off the facial nerve. And if you remember your anatomy, and hopefully you do, at least this much of it, the chorda tympani provides taste to the tongue on the ipsilateral side. Of course, there's two chorda tympanis, one on the right side, one on the left side, and it goes directly through into the petrotympanic fissure from the middle ear. This is the tympanic membrane, looking at it from the medial aspect of the middle ear, and through the petrotympanic fissure, also known as the Glissarian fissure, out of the petrotympanic fissure and then follows its course into the tongue for taste buds, which are all over the ipsilateral side, lateral, all the way back to from the anterior to the posterior portion of the tongue. At which point, if the chorda tympani is exposed to inflammation, it stands to reason that that nerve itself would not function correctly, would not able to translate its characteristics correctly, and it would cause burning tongue. I had not seen this before. I am not aware that I'm not aware, and it may be out there, that someone else, another anatomist like myself, has made this relationship. Certainly could be. Frankly, it doesn't make a whole lot of difference to me. I made the relationship, and it appears that in this particular case study, this patient had ongoing inflammation within the temporomandibular joint, documented, known. She had been getting better, but she went through a surgical event where the anesthesiologist opened widely, thus increasing the inflammation response to the overextension of the joint, increasing inflammation, which can, and in this case, I theorize that the inflammatory exudates got either up through the petrotympanic fissure or at the petrotympanic fissure into the middle ear, causing her burning tongue. Absolutely fascinating. I have not read of any accounts, whether there be single case studies or actual statistical studies of burning tongue associated with TMD. But that study can be done easily if you accumulate, half a dozen or even a dozen patients with burning tongue, and then determine whether or not they have inflamed joints. Push on the joints. Are the joints inflamed, or do they have a history of any of those other symptoms of TMD? It would stand to reason then that there is inflammation within the joint, which is directly responsible for the burning tongue. So how would you treat the burning tongue? How would this be converted into treatment? Would you use topical anesthetics? Would you use miracle mouthwash? I've had some patients who have claimed that other doctors have used other medications of various kinds, thinking that is a mental condition. I wouldn't recommend that, but I've heard that. Or would it stand to reason to just treat the TMD, decrease the inflammation, which would decrease the burning tongue? Well, those studies would be easy to do. And unfortunately, I and our company at this time do not have the money, resources available and people available to do that study. But I would make it, I would encourage anyone in academia who would like to do that study. It'd be an absolutely stunning study, because burning tongue is fairly common. That's why they have miracle mouthwash. That's why it's so common, at least here in the Southeast. I don't know how whether it translates into other areas of the country. But let's go back here. Oh, wrong way. The Glycerian fissure and the chorda tympani, which goes directly into the tongue, which when once becomes inflamed can cause burning. I appreciate your attention. I think that probably this is long enough considering the technicality of it. I hope I didn't bore you. I would like comments. I'd love some comments about what I brought to your attention or criticisms. I think that there is a lot to learn as deeper I get into this as a past operating oral and maxillofacial surgeon, trained both in medicine and dentistry and academia with degrees in cell biology and also gross anatomy. I think that I'm certain that there is a lot about TMD that we don't know. And it all revolves around inflammation, whether it be the cell biology of inflammation or the effect of inflammation on associated gross anatomical structures. There is a lot that we don't know about TMD, but I'm bringing these to light. And I'm able to bring these to light because we see in this practice such a huge number of patients and we treat them non-surgically. But, the opportunity to do, on average, 20 consults a week for patients who are referred in for TMD gives me personally the opportunity to see patients not only with the usual symptoms, but off-center symptoms that may or may not be related. Another one I just mentioned, and I don't want to go here, but it just comes to mind, is pain behind the eye. Pain behind the eye is one of those symptoms that I was exposed to and heard most often associated with migraine headaches. But I'm seeing more than a few patients who have the usual series of TMD symptoms, and one of their symptoms that they describe well is when it hurts, they have pain behind the eye. That's going to take some additional investigation and thought, but it seems to be that particular symptom also has some kind of relationship with TMD. Enough said about that. Emphasize, I think there's a lot we don't know, and there's a lot we can find out, and there's a lot of things that it can be done. I hope you've enjoyed this. Please, if you would like to join our network of providers who actually treat TMD successfully with a non-surgical device, we have the data, we have the academic study, independent university study showing that 85 to 95% of the symptoms diminish. The actual study shows the patient satisfaction of non-surgical treatment with the urbanic device is 85%. And that includes all these other symptoms of Meniere's disease and some of the odd symptoms associated we've discovered, arm, hand, finger tingling, and numbness associated with TMD. So for today, I'll wrap it up. If you'd like to contact me, my address is tony@tmjservices.net. Our Director of Marketing and Education is Naomi@tmjservices.net. Our website gives you all the information you need to join our network of providers. You have to take a course, online course, and then you can use the device. It's extremely successful. I am Tony Urbaniak, and this is TMD Demystified, and I look forward to the next time I get to speak with you.